I want you to imagine taking the delicate, constantly moist lining of the inside of your cheek, like literally pulling it outward and then exposing it to harsh, dry winter air all day,
Oh, wow.
right?
Yeah.
Every single day. And then, add in the constant friction of your clothing and just the relentless pull of gravity. It's a pretty wince-inducing image.
It sounds incredibly painful. I mean, just wincing thinking about it. And that intense environmental crisis is exactly what happens in advanced uterine prolapse.
Yeah.
You're basically looking at a situation where a tissue that evolved to thrive in this highly protected, dark, completely internally hydrated ecosystem is, well, it's suddenly forced to survive out in the outside world.
And that biological clash, that exact crisis, is really the core of our mission for this deep dive today. We are tackling a very highly specific question for you. Can a patient managing advanced uterine prolapse safely use ultra-high viscous hyaluronic acid suppositories to prevent external mucosal drying?
Which is such a great question because it sits right at this really fascinating intersection of traditional gynecological care and modern tissue engineering.
Totally. And to get you a definitive answer, we've pulled together just a massive stack of medical literature today. We're synthesizing peer-reviewed data from the American Journal of Medicine, the Menopause Journal, and we're also integrating findings from clinical trials on injectable hyaluronic acid.
Right, specifically looking at formulations like FGYN.
Exactly. And then we're cross-referencing all of those cellular insights with the absolute latest clinical guidelines on pelvic organ prolapse.
Because you really need that wide lens. I mean, you can't just evaluate a modern solution like hyaluronic acid without first understanding the underlying structural failure.
Right, we have to know what's broken first.
Exactly. We have to map out exactly what is happening to the body's tissues when a prolapse reaches that advanced stage.
And here's where it gets really interesting, honestly, because this shifts the entire conversation. Like, for decades, the gynecological playbook for vaginal tissue health was just entirely dominated by hormones.
Oh, absolutely. Estrogen was essentially the only answer.
But today, we're pivoting away from hormones, which is huge, and looking at this purely mechanical water-binding molecule. We're going to take you from the macro anatomical reality of a prolapsed uterus all the way down into the microscopic cellular magic of hyaluronic acid.
So let's start with that macro view, because before we look at the shield, we really have to look at the structural collapse.
The collapse, right.
In a healthy, functioning pelvic floor, the vaginal apex, so the very top of the vaginal canal, is anchored deep, deep inside the body. Clinically speaking, it sits roughly 5 centimeters below the S2 vertebra.
Okay.
And it's about 5 centimeters medial to the ipsilateral ischial spine.
Okay, medial to the ipsilateral ischial spine. For those of us who, don't spend our weekends casually reading Grey's Anatomy, you're essentially talking about it being anchored securely, like deep inside the bony bowl of the pelvis.
Right, deep inside. And crucial to this, it's held almost completely horizontally.
Oh, horizontally. I always pictured it vertical.
Most people do. But no, it doesn't point straight down like a vertical drain pipe. It rests on this thick, muscular hammock called the levator plate, and it's suspended there by the endopelvic fascia.
Which is that strong network, the cardinal uterosacral ligament complex, right?
You got it, that incredibly strong network. So when you cough or laugh or lift a heavy box, your intra-abdominal pressure spikes.
Right, the pressure pushes down.
Exactly.
Yeah.
But because the canal is horizontal, that pressure just pushes the tissue down harder into the muscular hammock, sealing it shut and basically keeping everything securely inside.
Which is brilliant engineering. But in advanced pelvic organ prolapse, that elegant hammock system just totally fails.
It does.
The supporting fascia stretches out, or in a lot of cases, it completely lacerates. And the medical literature outlines a few key culprits for this. You have the acute physical trauma of childbirth, obviously, which can physically tear those muscular support.
Create this sheer mechanical force.
Yeah. And then you have pudendal neuropathy, where the actual nerve signals to the pelvic floor muscles degrade, so the muscles atrophy just from lack of use.
Right.
And then on top of that, you have menopausal estrogen loss, which physically degrades the collagen holding all that fascia together.
And honestly, whatever the initial trigger is, the end result is the same. That endopelvic fascia loses its structural integrity. The uterus and the vagina lose that horizontal anchoring and they shift.
They start the drop.
Yeah. They begin to overlie the genital hiatus, which is the opening at the very base of the pelvis.
And then Gravity and abdominal pressure basically just take over. The vertical drop begins, and the organs bulge outside the body. And that mechanical drop is what sets off that environmental crisis we talked about right at the top of the show. Because that mucosal lining is definitely not skin.
No, not at all. It completely lacks the tough, keratinized outer layer that, your epidermal skin uses to protect itself from evaporation and friction.
Right, so it's hanging outside the body, suffering this severe desiccation just from normal ambient air.
Just from the air alone, yeah.
And then the friction of normal daily movement, like
Yeah.
walking, sitting, wearing underwear. It just acts like sandpaper on that delicate mucosa.
Which invariably leads to the formation of what we clinically call decubitus ulcers.
Okay, decubitus ulcers.
Yeah, these are essentially pressure sores directly on the prolapse tissue. They are incredibly painful. They bleed easily. They can cause significant odor due to, secondary bacterial colonization.
Ugh, that sounds awful.
It really is.
Yeah.
And they are notoriously stubborn to treat.
In fact, there's a specific clinical case study in our stack today that really highlights how desperate this situation can actually get. It details an advanced prolapse patient with this massive, wide decubitus ulcer that was just completely unresponsive to standard topical treatments.
The thing was working.
Right. They threw everything at it, normal saline washes, povidone iodine, and just nothing worked. The tissue remained raw and was actively degrading.
And see, this creates a terrible catch-22 for the patient and the surgeon. You would think the immediate solution is just, perform reconstructive surgery to put the organs back where they belong.
Just fix the anatomy.
Right. But you cannot operate on a massive active ulcer. The mucosal tissue in that state becomes highly friable.
Friable, meaning it's essentially like wet tissue paper.
Precisely like wet tissue paper. If a surgeon tries to place a suture into friable ulcerated tissue, the thread will literally just pull right through the mucosa.
Oh, wow. Just rips.
It just rips. It can't hold a stitch at all. So surgery becomes incredibly risky, if not totally impossible, until you can heal that exposed environment.
Okay, so we have this internal tissue trapped in an external world, desperate for a non-surgical way to build a protective shield, which finally brings us to hyaluronic acid.
Yes.
And I think, a lot of people hear hyaluronic acid and they immediately picture some expensive anti-aging face serum at a department store.
Oh, for sure.
So why are we applying a cosmetic ingredient to a prolapsed uterus?
Well, calling it a cosmetic ingredient really does it a massive disservice. Hyaluronic acid, or HA, is actually a naturally occurring non-sulfated glycosaminoglycan.
Okay, let's unpack this. Glycosaminoglycan. In English, we are basically talking about a massive, complex chain of sugars, right?
Exactly. It's a very long structural chain of sugars.
Yeah.
It is a fundamental building block of the extracellular matrix in the human body.
The extracellular matrix?
Right, so think of the extracellular matrix as the biological mortar that essentially holds all of your cells together. HA is found in huge concentrations in your skin, inside your joints as a lubricant, and critically for our discussion, throughout the pelvic floor fascial system.
And its superpower, like the absolute reason it is the star of this deep dive, is its water binding capacity.
Yes, HA is the ultimate humectant. It has this highly unique molecular structure that allows it to absorb and retain up to 1,000 times its own weight in water.
Wait, really? Up to 1,000 times? How does it even do that? It sounds physically impossible.
I know, it sounds like magic, but it comes down to hydrogen bonding. The sugar chains in HA are just packed with oxygen and hydrogen atoms, and they act like these microscopic magnets for water molecules.
Oh, interesting.
So when water gets near HA, it just gets trapped in this dense, tangled web of sugar chains. It becomes this thick, viscous, gel-like substance that absolutely refuses to let the moisture evaporate.
Wow.
So it provides just profound hydration to whatever tissues it surrounds.
But the clinical literature we read draws this massive, bold line under one very specific detail here, which is that not all HA is created equal.
No, definitely not.
The data focuses heavily on the distinction between high molecular weight HA and low molecular weight HA.
And this is a make-or-break distinction for treating something like a decubitus ulcer.
Okay, why?
Well, the molecular weight simply refers to how long that sugar chain is. High molecular weight HA consists of very long, intact, heavy chains. In a biological setting, these massive chains are highly protective. They form a robust structural barrier, and they actively soothe the immune system.
So they provide strong anti-inflammatory properties.
Exactly.
And the low molecular weight HA.
Those are short, chopped up, broken chains. And in the human body, short HA chains actually act like a biological alarm bell.
An alarm bell.
Yeah. When tissues are damaged or infected, the long HA chains get broken down into short fragments by the body. So when your immune system detects low molecular weight HA, it immediately assumes the structural scaffolding is under attack.
Oh, so it thinks there's an injury or an infection happening right there.
Right. And it immediately initiates a massive inflammatory cascade to fight off this perceived infection.
That is wild. So if you were to put a cheap, low molecular weight HA product on a raw, exposed prolapse ulcer, you would literally be tricking your own immune system into attacking the area.
Yes, you'd be triggering massive inflammation.
Yeah.
It would make the pain and the ulceration significantly worse.
Wow.
So for exposed mucosa, you absolutely must rely on ultra-high viscosity, high molecular weight HA to put out the fire, quiet the immune response, and lock in that moisture.
And practically speaking, patients are achieving this using suppositories.
Right.
We're looking at products on the market like Reverie, Evi, or Hyalogen. These are small, solid, bullet-shaped inserts that contain a highly concentrated dose, usually around 5 milligrams of that crucial high molecular weight HA, and it's suspended in this melting base.
Exactly. You place the suppository directly into the vaginal canal, or even just gently against the external prolapse tissue, and then your natural body heat slowly melts that base, releasing the HA directly onto the mucosa.
I do have to ask the obvious question here, though.
Sure.
If HA is ultimately just binding water to create a wet environment, how is this any different or better than just going to the pharmacy and grabbing a standard over-the-counter personal lubricant? Like, is a high molecular weight HA suppository just incredibly expensive lube?
I hear that a lot, but it is light years beyond a standard lubricant. And it all comes down to cellular osmosis.
Okay, how so?
Well, standard personal lubricants, whether they are water-based or silicone-based, are strictly surface-level products. They are engineered to just sit on top of the mucosa to reduce friction for a very short period of time.
Right, just a temporary slip and slide effect.
Exactly. But they do not improve the underlying cellular health. In fact, a lot of common commercial lubricants have a very high osmolality.
Meaning what?
That means they are highly concentrated with salts or sugars. Because of how osmosis works, when you put a highly concentrated lube on the surface of the mucosa, it actively pulls water out of the deeper tissue cells and into the vaginal canal to create that temporary slickness.
Wait, what? So it feels wet in the moment, but it's actually dehydrating the cells from the inside out.
Yes,
It makes the long-term dryness worse.
precisely. It's totally counterproductive for long-term health.
Right.
But high molecular weight HA is structurally and fundamentally different. When that suppository melts, those HA molecules don't just sit on the surface. They are integrated directly into the cells of the vaginal wall.
Oh, they actually go into the tissue.
Yes, they replenish that extracellular matrix we talked about. Instead of pulling water out of the cells, HA pulls moisture into the deeper layers of the tissue.
Physically plumping it up.
Exactly, physically plumping it up and restoring its natural elasticity.
So it's creating this highly durable 1000x water-binding barrier layer that defends against friction, and that deep cellular hydration can last for up to 72 hours from just a single application.
Which is incredible.
It's not just lubricating, it is facilitating active tissue repair.
Right, which naturally forces us to compare this mechanical powerhouse to the historical gold standard for vaginal tissue health, which is estrogen.
Right, estrogen. Because for decades, if you presented to a doctor with genitourinary syndrome of menopause or vaginal atrophy, the prescription pad came out for local vaginal estrogen, creams, rings, or pessaries.
Because as estrogen drops during menopause, the tissues of the vulva, the vagina, and the lower urinary tract essentially starve.
They physically thin out, right?
They thin out, they completely lose their elasticity, and the local blood capillary network actually shrinks. Estrogen therapy works by binding directly to hormone receptors inside the tissue. It sends a biological command to the cells to rapidly divide.
So it physically thickens the mucosal lining back up and restores that dense cellular architecture and blood flow.
Right, it rebuilds the wall.
Which, that sounds like the perfect biological fix. Estrogen fundamentally rebuilds the wall from the inside out. So how on earth does a heavy-duty sugar chain, even one that holds 1,000 times its weight in water, compete with that kind of hormonal reconstruction?
It's a fair question, but when you look at the head-to-head randomized clinical trials, the results are actually staggering.
Really?
Yeah. For women managing mild to moderate vaginal dryness, high molecular weight HA produces symptom relief that is entirely comparable to low-dose vaginal estrogen.
Comparable, like statistically the same?
Yes, statistically significant and comparable. Within 4 to 12 weeks of consistent use, the patients using HA report massive reductions in itching, overall dryness, and dyspareunia.
Dyspareunia, which is severe pain during intercourse.
Right. And the monumental advantage here is that HA operates completely outside the endocrine system.
Right, because it's not a hormone.
Exactly. It doesn't use hormone receptors at all. It works purely on structural mechanics, which makes it an absolute game changer for breast cancer survivors, patients on aromatase inhibitors, or just anyone who simply cannot or will not risk systemic hormone absorption.
That's huge. But if we pull up the data specifically on advanced prolapse and those brutal decubitus ulcers, we actually found a really surprising caveat about estrogen's limitations in the sources.
Yeah, that retrospective cohort study.
Right. There's this fascinating retrospective cohort study in our literature stack that tracked prolapse patients who were using commonly prescribed vaginal estrogen therapy. And the researchers found that the estrogen was actually not protective against vaginal ulcerations or bleeding for a lot of these advanced prolapse patients.
Throws people off.
Yeah. Wait, so if estrogen isn't always protecting against these decubitus ulcers anyway, does that mean HA is actually the undisputed heavyweight champion for advanced prolapse patients? Like, how could estrogen fail to protect them?
It's because of the environment. Think about what estrogen actually does. It physically restores the thickness and the cellular health of the mucosal wall. But for a patient with advanced prolapse, that newly thickened healthy tissue is still hanging outside the body.
Oh, right.
It is still rubbing against cotton underwear all day. It is still fully exposed to dry ambient air.
Ah, I see. Estrogen rebuilds the wall, but it doesn't put a bumper on the outside of the wall to protect it from the elements.
Exactly. It completely lacks that external viscous water-trapping shield. Estrogen does not create a mechanical barrier against friction, but hyaluronic acid is uniquely engineered by nature to provide exactly that kind of external lubricating armor.
Which means they aren't enemies in this fight at all. They just play different roles.
Right.
So a doctor could theoretically prescribe estrogen to, like, biologically thicken the mucosal architecture, while the patient simultaneously uses HA suppositories to wrap that exposed tissue in a durable, hydrating, anti-friction force field.
They can absolutely be highly complementary therapies.
So what does this all mean for the safety aspect? Which brings us right to the core of the mission we set out to answer for you today. We've established that high molecular weight HA is incredibly effective. We know it physically hydrates at a cellular level, it rivals estrogen for symptom relief, and it acts as this much-needed mechanical bumper against external friction.
Yep.
But the ultimate question for someone managing an advanced prolapse day in and day out is it completely safe to use these suppositories on a long-term basis?
Looking across all the clinical guidelines and trial data, the answer is a resounding yes. The safety profile of hyaluronic acid is just virtually unmatched.
Because it's natural, right?
Because it is an endogenous substance, meaning your body already naturally produces it in massive quantities every single day. So your immune system inherently recognizes it as self.
Got it. So the risk of triggering some kind of allergic rejection is just incredibly close to zero.
Basically zero, yes. And regarding the duration of use, which is vital for advanced prolapse, because if a patient isn't a candidate for immediate reconstructive surgery, they are managing this tissue exposure indefinitely.
Right. This is a daily reality.
Exactly. And the clinical studies show that HA can, and frankly should, be used indefinitely. Vaginal tissue atrophy and prolapse-induced drying don't spontaneously cure themselves.
Yeah, sadly no.
In fact, they compound over time. The longer you consistently use a high-quality HA suppository, the better the long-term outcome, because that HA cumulatively builds up inside the extracellular matrix.
So it permanently upgrades the tissue's hydration capacity.
Exactly. It builds a reserve.
We do have to look at the fine print, though, for you. Are there any documented side effects we need to be aware of? I know you mentioned inflammation with the low molecular weight stuff, but what about the high-quality suppositories?
Side effects are very rare, but they usually center around mild irritation or a temporary burning sensation right upon insertion. But context is everything here. If a patient's prolapsed mucosal tissue is already severely desiccated, covered in microscopic friction tears, or actively ulcerating.
Oh, I see. Literally anything that touches that raw nerve ending is going to sting initially.
Right. It's almost never a chemical reaction to the HA itself. It's just a physical reaction of raw, damaged tissue being manipulated.
That makes total sense. The clinical guidelines also note that unusual vaginal discharge is a pretty common side effect.
Yes, but again, that is purely a mechanical reality of how a suppository functions.
Because of the base melting.
Exactly. The active HA has to be suspended in a base, Usually it's like a hard lipid or a botanical oil that remains solid at room temperature but then melts perfectly at internal body temperature.
Right.
Once it melts and delivers the HA into the cells, well, that lipid base has to go somewhere. It naturally exits the body as a noticeable discharge. It's not a sign of infection or a bad reaction. It's literally just the carrier vehicle leaving the station.
Which actually perfectly explains why the guidelines specifically recommend suppositories over gels for this demographic.
Oh, absolutely.
Because if you use a vaginal gel, you usually have to insert it using this hard plastic plunger-style applicator. And dragging a hard plastic tube across a prolapsed, friable, highly sensitive mucosa is basically a recipe for creating even more micro tears.
Suppositories completely eliminate that trauma. You can place them exactly where they are needed using just a clean finger. They are far less messy than gels, and as they slowly melt, they provide this highly targeted, sustained release of hydration directly into the damaged cellular walls.
So synthesizing everything we've looked at today, for you, our listener, this means that yes, if you are managing the intense external drying, the daily friction, and the serious ulceration risk of an advanced uterine prolapse, the data is incredibly clear.
Very clear.
Utilizing ultra-high viscosity hyaluronic acid suppositories is a scientifically backed, exceptionally safe strategy. It allows you to build a 1000x water-binding shield over that vulnerable tissue, and it delivers deep cellular relief that goes toe-to-toe with traditional estrogen therapy, but it completely bypasses the endocrine system.
It is a profound tool in conservative management.
Mm,
You're essentially taking the body's own biological mortar and weaponizing it against an unnatural environment.
I love that phrasing. We've covered massive ground on this deep dive. We started by mapping out the mechanical failure of the levator plate and the endopelvic fascia that, causes the uterus to drop, thrusting that delicate internal ecosystem out into the harsh, dry air.
Covered a lot of
We
anatomy.
did. And then we zoomed in on how high molecular weight glycosaminoglycans use hydrogen bonding to trap 1,000 times their weight in water, acting as this soothing anti-inflammatory shield. We explored why it rivals estrogen in clinical trials while offering a crucial physical barrier that hormones alone just can't provide. And we confirmed that using these suppositories indefinitely is overwhelmingly safe.
But before we sign off, there is one final, truly fascinating concept hidden in the research that points to where the future of pelvic floor therapy might be heading.
Ooh, okay, lay it on us.
It all revolves around an enzyme called hyaluronan synthase 2, or HAS2.
Okay, HAS2. What does this enzyme actually do?
So HAS2 is the microscopic biological machinery that lives inside our own cells. It is the factory responsible for synthesizing our endogenous hyaluronic acid.
Okay.
It directly controls the hydration, the lubrication, and the elasticity of our tissues naturally. Right now, our entire approach to prolapse dryness relies on delivering HA externally. We insert a suppository, it melts, and the tissue absorbing it.
Right.
But tissue engineers are beginning to look at HAS2 as a primary therapeutic target.
Wait, so instead of delivering a finished batch of HA to the tissue via a melting pill, scientists are trying to figure out how to just flip the power switch on the HA factory already inside the cells?
That is the frontier. I want to leave you with this provocative thought. What if the future of treating complex pelvic floor disorders isn't about indefinitely relying on external moisturizers or even external hormones?
Okay.
What if the next massive medical breakthrough lies in targeted therapies that can just modulate our own HAS2 expression? Imagine a treatment that effectively teaches a damaged prolapsed mucosa to aggressively synthesize its own high molecular weight HA, intensely repairing and hydrating itself from the inside out.
Wow. That is absolutely incredible to think about. It brings this entire journey full circle. We aren't just looking at a static anatomical failure. We're looking at a highly dynamic living cellular ecosystem.
Exactly.
And while a prolapse might expose that ecosystem to the harsh winter air, the science of hyaluronic acid, whether we are delivering it via suppository today or perhaps triggering it from within tomorrow, prove that we have profoundly powerful ways to help that tissue adapt, survive, and honestly heal.
It really is a testament to the sheer resilience of human biology, as long as we provide it with the right structural support.
Absolutely. Thanks for joining us on this deep dive. Keep asking great questions, and we'll keep tracking down the answers.